और थोड़ा सामने आओ. हाँ, यस. ठीक. हाँ, स्टार्ट करो. 8:45 हो गया. स्टार्ट. हाँ, हाँ, स्टार्ट करो.
Good morning, respected sir, my seniors and my colleagues. Today I will be presenting a case of gluteal mass. Okay, 18 years old female presented with a large swelling in the left gluteal region since birth that started as a black mole which gradually increased in size to reach the present dimensions, that is 15 into 13 into 10 centimeters. She also presented with pain in left leg for the last 1 month that was shooting pain from lower back to leg that started suddenly and was associated with numbness and tingling sensation. There was no history of periodicity or progression of pain, and there are no aggravating or relieving factors. There was no history of fever or weight loss. There was absence of any other lump on any other side, any pigmented spots, inguinal or axillary freckling, any impairment of function of limb, or any obvious spinal deformity. There was no history of any learning disorder or mental disorder. In the past, she was operated for the swelling at the age of 7 years, and the biopsy reported it to be rhabdomyosarcoma at that time. The family history was not significant. On general examination, patient was alert, conscious, and well oriented. There was absence of pallor, icterus, cyanosis, clubbing, edema. There was no visible neck veins, and there was no palpable neck glands or neck nodes. Her pulse was 78 per minute, regular, without radioradial or radiofemoral delay. The BP was 110 by 80 millimeter of mercury. Respiratory rate was 14 per minute. Patient was afebrile. Patient is well hydrated, well nourished, with a Karnofsky performance score of 90. On local examination, there was a large solitary 15 into 13 into 10 centimeter swelling occupying whole of the left gluteal region with well-defined edge, firm in consistency, non-tender, having a bossulated surface with visible scar and areas of pigmentation seen over the swelling. There, without any muscle wasting, any rise of temperature, or any compressibility. The swelling was non-pulsatile, fixed to the underlying muscle and fixed to skin at some places. The sensory and motor examination of the lower limb was essentially normal. So this was the swelling. Here we can see the scar mark over the swelling and areas of pigmentation. This is another view. Her systemic examination was essentially normal, with cardiovascular system S1, S2 heard normally without any murmurs. Her chest was bilaterally cleared. She was well oriented to time, place, and person. Her abdomen was soft and non-tender. So, despite the previous biopsy diagnosis of rhabdomyosarcoma, we kept our provisional diagnosis as hematoma because rhabdomyosarcoma usually never present with such a long history. In our differential diagnosis, we kept sarcoma low grade, lymphatic malformation, venous malformation, and plexiform neurofibroma.
Give 5 points for and 5 points against, or 2-3 points for and 3 points against each of your differential diagnosis. Why did you consider this? Each one.
Well, basically every diagnosis was based on the location of the swelling,
yes,
the presentation, that is slow history taking long time, each one of without any pain or tenderness. Each of the diagnoses usually present as like this only. So we did some routine investigations that was necessary, and some investigations to rule out neurofibromatosis, as we kept our diagnosis as plexiform neurofibroma also, which is mostly associated with neurofibromatosis 1. So the ophthalmological examination was done to rule out Lisch nodules, and they were not found. X-ray dorsolumbar spine was done to rule out scoliosis, and X-ray of the skull was done to rule out sphenoid dysplasia. And other ultrasonography of the abdomen was done, and it was normal. We did a core needle trocket biopsy, and it revealed 3 fragments, one of which is blood clot, other 2 show fibrotic collagenous spindle-shaped monomorphic cells in a loose edematous background. So impression was difficult to differentiate between fibrocollagenous or a spindle-shaped benign lesion. So we did an MRI to delineate the swelling. The MRI revealed it mass of 15 into 12 into 10 centimeter in the left gluteal region involving gluteus maximus and vastus lateralis. The lesion is hypointense to muscles on T1 and hyperintense on T2 weight images. The lesion was involving the obturator neurovascular bundle in medial compartment and sciatic neurovascular bundle in posterior compartment. The bones were not involved. So here we can see the swelling. Here it is invading the muscles. This is the hypointense picture, and this is the hyperintense T2 weight image. So after explaining the patient,
just summarize you in 2-3-4 minutes. Summarize everything. Now, up to now.
Well, an 18-year-old female presented with a large swelling in her gluteal region with associated complaints of pain. The swelling was since birth, and she had pain for the last 1 month. On examination, the swelling was involving the gluteal region. It was about 15 into 12 into 10 centimeter in size, and there was no tenderness, no compressibility. Swelling was firm to touch, and there was no local rise of temperature. Her examination of the lower limb was essentially normal, and her systemic examination was normal. The routine investigations were normal, and the investigations taken to rule out neurofibromatosis 1 was also normal. So we came to the diagnosis of hematoma despite the previous biopsy diagnosis of rhabdomyosarcoma, and with that we did a cone needle biopsy that did not give us a confirmed diagnosis, and an MRI that revealed the extent of the lesion involving the neurovascular bundle. So with this, after explaining the patient that if after doing the procedure there would be possibility of serious neuromuscular weakness and sensory loss in the lower limb, and taking her proper consent, we did 3D wide excision. We took the decision of 3D wide excision of the tumor under GA and performed the operation on 19/11/12 with reconstruction of the defect with superior gluteal perforator flap and slight swing posterior thigh flaps with split thickness skin grafting to cover donor side defect. This is the operative picture, and here you can see the MRI was not completely right because we could easily, we were able to separate the swelling from the sciatic nerve. So the swelling was not exactly involving the sciatic nerve. This is another picture. So this was the complete defect after removing the swelling. Here we see the sciatic nerve has been saved. So this is the picture of the reconstruction that has been done with superior gluteal artery perforator flap and slight swing posterior thigh flap, and this was the donor side defect that has been covered with skin graft.
So there was not much adhesion around.
The adhesions were there, that it was cleared, but it was not involving the nerve bundle.
Adhesion in the
Infiltration. This is another picture of the repair of the defect. So in the post-operative period was uneventful, except that there was superficial necrosis of the slight swing flap at the upper part, which was managed with wound debridement and dressing. And after 3 weeks, secondary suturing was done. So histopathological examination of the specimen revealed a spindle-shaped lesion arranged in fascicle and cartwheel fashion and forming nodules. No bizarre cells or mitotic activity is seen. So it reported it plexiform neurofibroma. So our final diagnosis was solitary plexiform neurofibroma without neurofibromatosis 1. So this was the gross specimen showing the nodules. These are the nodules. This is another picture where we can see the different size nodules. Now this is the photomicrograph in low power where we can see spindle shaped cells arranged in clusters at some places. Where in high power it is clearly seen that the spindle shaped cells are arranged in clusters. When we go in more high power, we see these spindle shaped cells are nerve fibers and not muscle fibers as they have elongated nucleus. So this is the follow-up picture after 1 month, and we can see the defect has been completely healed. This was the site from where skin graft was taken. So plexiform neurofibroma, these are benign